We are live now, doctor.
Thank you. Hello and welcome everyone for today's live webinar by Glaucoma Society of India. We had a good webinars last year and we are starting this year's webinar programs. I welcome each and every one of you for this wonderful webinar on the Spectralis OCT, especially on glaucoma and to an extent to the neuroophthalmology. Today we have our special guest. Thank you, Mr. Martin, for joining with us today. I will just explain or introduce Mr. Martin. Mr. Martin is an MBA business graduate with 46 years of experience in ophthalmic diagnostic and surgical instruments. He has worked with the Keeler, Allergan, Humphrey, Zeiss, Hagstreit, and he is with the Heidelberg Engineering for the past 25 years. As head of international sales and marketing, US General Manager, Area Director, Europe, and now Director of Professional Education. He has worldwide experience of ophthalmology, specializing in glaucoma and imaging. Martin is part of the Heidelberg Academy, supporting educational events and teaching the clinical use of spectralis OCT in retina, glaucoma, and also in cornea. And more recently, we know that we have taken up, there is another instrument from Heidelberg, the Anterion. So he's kind of engaged with teaching on the Anterion also in the recent time. So he has represented Heidelberg Engineering and the World Glaucoma Association as well. So with the vast experience in Heidelberg and being in ophthalmology for almost 45 years or 46 years, we would like to welcome you, Mr. Martin, for this wonderful evening. And we are ready for the show. Over to you.
Thank you, Dr. Satyan. It's very kind of you. Thank you very much for the invitation. I'd like to share with you what at least I've learned about the essence of good imaging. So let's get going. I like to call it a special glaucoma DNA, if you like, on the Spectralis. And we talk about image quality. We talk about anatomic positioning, high reproducibility, very important. Sensitive nerve fiber layer circle scans, for example, and full raster averaging. That's averaging within the volume scan or the cube. Segmentation is very important. And we think we have a way to identify earlier change. It's a holistic evaluation that maybe allows us to discriminate glaucoma from neuro-ophthalmology. And this should increase our clinical confidence, I think, at the end of the day. So what technical components do we need for good imaging? I think, first of all, confocal optics is one. We have dual beam live eye tracking. And we have the art of OCT, which is automatic real-time meaning or averaging. We have full raster averaging, that's averaging in the cube. And we have auto rescan to be able to come back to exactly the same location for the follow-up. Let's talk about the image quality. Image quality comes from confocal optics. That's what gives us these very nice images. For those of you who are not aware what confocal optics is, we are sending a laser light to the back of the retina. And when the signal comes back, we put it through a confocal pinhole to the photodetector. And we only take the information that's actually in focus. If we then look at information coming, let's say, from behind the retina is out of focus, we block it. So we only get the information that we want. If you scan or take a picture of the fundus with a fundus camera, it's a one big white flash of light, try to capture everything all at once. But what we're doing is confocal scanning laser, and we're doing pixel by pixel capture, and we don't get the light pollution that maybe you get with a standard fundus camera. It's very quick. There are advantages to this. So first of all, we get individual illumination of the pixels. And the confocal pinhole excludes any scattered light and only allows information that we want from our point of focus. So focusing becomes quite important in some of the imaging that we do. you get an enhanced image contrast. You get detail and sharpness. And even with your focus, you can go underneath the retina and get excellent choroidal images. That was one of the big benefits when we moved into angiography, particularly in designing green angiography for looking at the choroid. It's a very low light exposure. It's 1% of the flash of a fundus camera. So it's a little bit safer and more comfortable for the patients, at least anyway. And one of the best things about it is you can image through undilated or small pupils. So diabetic patients don't dilate very well, so it's better for imaging them. And also cataract and cornea tends to scatter the light. And so we avoid the light scatter. If you try to image, let's say, a glaucoma patient that you're suspecting with a fundus camera, you might not get any image at all. And if you have cataract, you just get a blanching of the whole image. So the light scatters right across the image there. So you can actually get an image through confocal optics because we're focusing underneath the cataract.
Martin, is it from your side, the dogs, or is it from
Yeah, sorry. Somebody walked past the house. I'm really sorry about that.
Okay. But I just wanted to make sure it is not from any of our side.
Yeah, what I can do is I put them in the back. Do you want me to walk and put them in the back?
No, I mean, if they stop, it is fine. Otherwise, we can probably close the door. Yeah, I think it is okay now.
Yeah. Let me put them in the back. Come here. Come here. In. Oh, I'm really sorry. I apologize for that. I had put them in the back and then they were all quiet and I thought I will be okay, but not. To continue, you might get images like this, and from an infrared reflectance image, it's a structural image, and you can see very nicely the optic nerve. You can see the vessel trunk. You can even see nerve fiber defect with infrared. In multicolor is another option that we have. Look, you can see the nerve fiber raphe even. So these are structural images more than anything, rather than let's say a two-dimensional color fundus photograph, for example. So a little bit different. You can see the discs very nicely. I can see the pores of the lamina here in this image of this, let's say, an advanced glaucoma optic nerve, for example. And interestingly, I'm not sure whether this is stereo or whether it's 3D, but in multicolor, that probably illustrates how multicolor comes. It's almost a three-dimensional function compared to our two-dimensional fundus image. So they're different. You can see nerve fiber layer defects very nicely with confocal multicolor. I struggle to see on this fundus camera this nerve fiber defect, but I can see very clearly with confocal multicolor because we're focusing on the short laser wavelengths at the surface of the retina. You can see the optic nerve head structure with the radial scan and see what's happening there if you want to. And the beauty of your spectralis is that you get a very clear and large image of the nerve fiber tissue. You can see the tissue and you can see that that's segmented properly. And if you can see that, you can see whether or not there are any problems or whether that segmentation is correct or not correct. Then you can be very confident about the profile that you see of the nerve fiber and the measurements that you get from it. Here's an example where we've got some cystic space in the nerve fiber there. So it's going to be very, very difficult to monitor our patient if we're worried about them from a glaucoma perspective. So you can see that immediately. You can see epiretinal membrane. So you know that your nerve fiber measurements that you get are not necessarily going to be that useful because you're not really measuring the nerve fiber. And there's a little missegmentation there as well. You can see very obvious segmentation errors here. Look, there's a bad error here. And if I look on my segmentation button, I see the most obvious error that we usually see with OCT is a clipping of the nerve fiber layer because the camera is too close to the eye. So it's a technician issue more than anything else. And so look out for that because that's the most common one. You want to make sure you're in the right location when you do the image. We see the retinal layers very clearly. In fact, you can see from the vitreous through the neurosensory retina, all the layers of the retina, right down to the choroid and the sclera. So it's a very clear image that you get now. What does that mean? It means that we should get better segmentation because we can see those layers properly. And that means we should get accurate measurements. Why are the images so clear, you might ask yourselves? Confocal optics eliminates light scatter and it increases contrast, a little bit like a zebra. A zebra is a contrasting animal, for example. These are my beautiful sunflowers from Spain, and you might look at the sunflower and say, oh, that's a little bit fuzzy. I'd much rather see it like that. And you might say, well, that's just because we've got a better resolution in that image compared to the other one. But in reality, it's actually the contrast that's important, that determines the resolution. So can you actually see two structures that are close together and separate them and see them as separate entities? And that's the ability of confocality, if you like. Our color fundus photograph here is the gold standard from an imaging perspective if we're looking at fundus pictures. But I can see a nerve fiber defect in that fundus picture, but I can see it very clearly in confocal multicolor because we're looking at structure. And I might be able to see another one and even another one that I don't see in the color fundus photograph. And look at the pixels. You've got 3 times the pixels in the color fundus photograph compared to the multicolor. So it's about contrast. It's not about pixels and resolution of pixels. We can see more with less pixels, in fact, because of confocal optics. The contrast provides the resolution. So you can see structural detail. This is a very good high quality color photograph, but it's a little bit fuzzy. It's not quite as distinct in terms of the structure. Not talking about color, structure. And I especially think confocal optics help with difficult eyes. These are all the difficult eyes, apart from your advanced glaucoma cases that you have. And I think you can successfully image a higher percentage of patients that come to your clinic because you're probably faced with all the difficult patients referred to you. And some of our OCTs struggle to image those patients. So I think you've got a better chance, maybe 10%, where you need the extra effort, you can get it. So I think you improve clinic efficiency because of that. And when you've got abnormal and pathologic eyes, I think Spectralis gives you an extra gear. And this is just the start. Our DNA thread runs through everything that we do. Let's talk about anatomic positioning, APS. We've learned that every single eye has got a different orientation of the fovea to the disc, and nobody's accounting for that in their OCT. And you could see a variance in the angle there of +2 to -18. I've seen some higher than that even. And if you actually adjust from +2 to -18, you see that you shift the profile of your nerve fiber against the normative database, and you can change the classification of the patient if you're trying to identify whether they seem to have a problem or not. We might call that so-called red eye disease, if you like. So what we do is we automatically identify the fovea, first of all, and then we go to the optic nerve and we identify 4 primary points of Brooks membrane opening, which should be the true clinical disc margin. And we center the disc according to those first 4 primary points. It's a little bit like visual fields, where we set our hill of vision according to the first 4 primary points, because that's what we're expecting the patient to be able to see. Then we fix the axis for every single eye individually. It's called fovea to BMO axis before we start scanning, and then we start scanning. And we do a radial scan to look at the neuroretinal rim. We do a circle scan to look at the peripapillary nerve fiber, and then we do a complete posterior pole scan to segment all of the layers and look particularly on the ganglion cell layer. This is really important now, especially in non-glaucoma, because you see changes in the ganglion cell very early. If you look then at our anatomic positioning, and I ask the patient to move their eye, you see that we're locked in position. The fovea is locked to the center of the disc. All right, so this is a fundamental technique to help improve our reproducibility and avoid red eye disease artifact, if you like. It's anatomically correct. So we match the configuration of the axons. It doesn't matter if you have a sloping orientation or you have a horizontal orientation. We're actually comparing and normalizing every eye to each other. We're looking at exactly the same location of the nerve fiber raphe, for example. What does that mean? It means we reduce the artifacts and we get accuracy. High reproducibility is very important. You probably know this is a slide courtesy of Andrew Tatham, who's currently the president of the UK and ERA Glaucoma Society, and probably you know him. And Andrew says, look, we think as glaucoma people, the average nerve fiber layer thickness has an intervisit variability of about 4 to 5 microns in general with OCT. But actually, your Spectralis has a much better reproducibility at level of 1.14. And I'm happy to share this paper with you if you want it. Just let me know, or maybe you have already seen it. I don't know. So if other OCTs have 4 to 5 micron reproducibility and Spectralis has 1.14, how is that possible? And I would say I think it's possible mainly to dual beam live eye tracking. Heidelberg was the very first company to come with eye tracking when OCT came out in the form of spectral domain, and then everybody's copied the eye tracking concept. So everybody does eye tracking. It's become an industry standard. But Heidelberg was the first to do that in 2007. It gives us reproducibility. So if you don't track the eye, you're chasing your fundus all the time, and the OCT is always at a different position. And maybe that's why you might get variable nerve fiber layer results from one exam to the other. Some people tell me I get 4, 5, 6 micron difference. Why is that? What we do is we lock to the fundus. We always know the location of the OCT. And if you look at these two scans here, I've got a cube scan here, and you see the eye's moving behind the scan while you're scanning. So it's constantly moving. What we do is we lock onto the eye and we move with the eye. And I show you the circle because it's easier to see. But all of these circles have to line up. If they don't line up, we throw away the data. We don't keep it. All right. So every circle has to match, and we do 16 scans per second. So we don't give you any bad data. That has all to be in line. So it's the combination of the live eye tracking and maybe the anatomic positioning that gives us this very high reproducibility, because we're controlling the position and location of the tissue that we're measuring. On retina, you get exact registration, and this can be demonstrated on any case, even ones that maybe you have, and you see that the OCT is exactly aligned to the fundus image if you look at the shadows of the vessels by comparison. It's not software tracking. Many of the OCTs try to include software tracking, and be careful, because unbeknownst to you, your technician often switches off any tracking if they have tracking, because it tends to hold the scan, and they just want to get their job done quickly. They are not so interested that they're not giving you properly tracked OCT. So just be careful. What does that mean? It means you get accuracy. It means you've got precision, and you've got reproducibility. And if we think these are features, what's the benefit? What's the benefit of those features after that? You get reliable follow-up. You might see earlier changes. I would suggest that's better glaucoma detection, or possibly earlier confirmation of glaucoma progression, if we consider that that might be actually the first confirmation of glaucoma detection, in fact, via progression. You get clinical confidence because you've got confidence in the information that you're getting, and you can improve your patient management because of that. You might get a reputation for excellence because you're doing such good work, and you might attract more patients. Maybe you have enough patients already, I don't know. We have sensitive nerve fiber layer circle scans. This is because of the art, for one reason. The art is the art of OCT, I call it, and this is automatic real-time meaning or averaging of the B-scan images. And this is another thing that Heidelberg developed, first of all, and has become standard practice. So there's a lot of speckle noise in OCT scans. And so if you put two OCT scans together, you can isolate where that random noise is, and then you can filter it away and just look at the tissue, which is what we want to look at. So this is the idea of averaging. We're getting rid of the noise. And that's the reason why we have such high contrast images with less speckle noise than there would have been. And if you look at this series of scans, what we're doing is getting rid of that random noise and just showing you the true tissue signal. And the images have better contrast and detail. So if you look at the top here, we've got an ART1 scan, which is very grainy. But by the time you put 100 images into one, which is very, very, very quick to do, you actually get a much clearer view of what you want to see. So this might be what you're looking at right now, because this is typically what you see in an OCT cube. What we're doing on the circle scan is an ART100, 100 OCT scans in one. And you can see the individual layers much clearer. Here's your circle scan by comparison. Maybe you're looking at this today, something like that. I'm looking on something like this, which I think is a little bit clearer. And so my question to you all is, how much art or averaging does your nerve fiber layer circle scan have to improve the quality of the segmentation and the measurements? Can you see the segmentation clearly and check it's correct? Can you manually change it if it's not? If you look at the circle scan, here's our Spectralis circle scan, and you'll see there's lots of data points on the circle scan. A lot of the OCTs are taking the circle scan out of the cube, and you'll notice that there's bigger spaces between the data points and less data points. Okay, so I call this a dedicated circle scan, and we have 768 data points on that circle. A circle coming out of the cube is a cube-derived circle scan, and you've got a third of the data points, 256 data points. So that circle's coming out of the cube, okay? And it makes a difference. You see much more detail and a truer representation of the actual surface of the nerve fiber layer compared to this smoothed out, interpolated, computer-produced version, if you like. So there's a big difference between the sensitivity of those nerve fiber circle scans. That's a circle scan coming out of a cube. I would say dedicated circle scans have 3 times the data points of a cube-derived circle scan. And what does it mean? It means you've got less interpolation, you've got higher sensitivity, you'll focal defects earlier, certainly you'll see tissue loss earlier, and you've got an improved clinical ability. Full raster averaging. I call it cube art, art within your cube. Our live eye tracking allows averaging of all the B scans in your volume scan or your cube. They're called OCT rasters for jargon. But look at the difference between what you might be seeing today. In your cube, you've got single ART1 B scans, and that's what they look like. And in our cube, we would do a posterior pole scan, for example, for our glaucoma, and we're using ART9. And you actually can see the membrane here. You can see all the individual layers. You can see the external limiting membrane properly, whereas you can just vaguely see it there. So it is a big difference. And what does that mean? That means you should get better segmentation, and that should give you accuracy. You should get reliable ganglion cell and deviation map analysis. And here's a paper from Kuris Nurumadavi. I don't know whether you know him, but they've studied this, and they reported, look, changes in macular GCIPL were detected more frequently on Spectralis volume scans than those of serous OCT, just for the record. Question to you again, how much art or averaging do you have in your cube to improve the quality of your segmentation and the accuracy of your measurements? Segmentation is really important. We look on the inner retina layers in glaucoma, All right, we look at the nerve fiber layer, the ganglion cell layer, the inner plexiform layer. And interestingly, you would see between early and moderate to advanced glaucoma, there's a sharp drop in thinning, thickness of the ganglion cell. So the ganglion cell is very important to be looking on. Typically, in a normal eye, GCIPL, if you combine the two layers, the nerve fiber layer and the inner plexiform layer, is about 85 microns in a normal eye. Ganglion cell just under 50, and inner plexiform probably 35, 36, something like that. I get asked often, which OCT is best for glaucoma, spectral domain or swept source? And I would answer citing this paper from Lee, Kim, and Kim. In general, shorter wavelength spectral domain OCT has better optical depth resolution for the inner retina layers. And that's a general concept. The averaging of multiple images that are, if you like, of spectralis enhances the image contrast. And it's the combination of these two things which facilitates segmentation of layers that have low contrast, like the ganglion cell layer and the inner plexiform layer. And macular inner layer analysis in this paper using spectralis was better at differentiating glaucomatous eyes from healthy control eyes than swept source OCT. Furthermore, the lower resolution of swept source results in low detectability of damaged inner retina layers, and that may be due to the lower accuracy of the segmentation. That's what's suggested. Spectralis was better than swept source for measuring GCIPL thickness in the outer temporal zone, irrespective of the degree of visual field damage. And this is the zone where glaucomatous ganglion cell damage occurs most frequently. And that suggests the superiority potentially of spectralis over swept source in diagnosing glaucoma in the macular region. And this is a key area that we look at across the horizontal midline, the upper value here compared to the lower value. And in early to moderate glaucoma, you see this snail shell pattern, this notching of ganglion cell, particularly inferiorly, is more common. Finally, spectralis was more sensitive than swept source in evaluating GCIPL for glaucoma diagnosis in early, moderate, or advanced glaucoma. I think that's relative to the visual field, let's say, denomination of glaucoma. We have 10 layers that we segment compared to swept source, which has had only 5. I think some of the more new Chinese swept source devices are up to 6 and 7, but still not the whole. So for segmentation of inner retina layers, I say spectralis, spectral domain OCT, has better contrast and resolution than swept source. What does that mean? You get improved clinical ability. You've got diagnostic confidence. I think if you're not sure a patient has glaucoma today, you're into progression. And you monitor them to see if they change in the way of glaucoma. And Roger Hitchings once told me in Moorfields, who you probably remember him, he's retired now, but he was the head of glaucoma service in Moorfields. He said, Martin, glaucoma is all about progression. Glaucoma evaluation with OCT is all about reproducibility. Your ability to diagnose glaucoma with OCT depends on 2 things. Firstly, can you reliably come back to the same piece of tissue to check for change? And then what precision can you measure that change to confirm glaucomatous damage? And I think this live eye tracking allows you to confirm progression accurately and help to diagnose glaucoma if that's the case. We do auto rescan. So knowing where the scan is taken first time is important. Knowing where the scan is taken in follow-up is critical. So we use the fundus image like a fingerprint, and we automatically follow up scans precisely in the same location. There's about 1,000 landmark positions in the fundus image, and we lock to those landmark positions when we do the follow-up. So you get exact alignment of follow-up scans, and then we continuously live track those follow-up scans to get accurate progression and hopefully accurate diagnosis and treatment. Better patient management gives you clinical confidence. It's like a domino effect. You must come back to the same piece of tissue to confirm change, and clinically significant change probably generally thought is 4 to 6 microns, something like that. Spectralis has a detectable change of 1 to 2 microns, and that's the eye tracking that makes that possible. Some numbers. Normal aging loss in nerve fiber, average nerve fiber, is about 0.5 micron a year. Glaucoma patients lose 2 microns a year. So I would say we might be able to confirm progression, let's say conservatively at 18 to 24 months. If we lose 2 microns a year, that will be 4 microns after 2 years, and our reproducibility is at level of 1. Some OCTs may take longer, 4 to 5 years I've seen, or even longer sometimes. So the question is, your mum, what would you do? If it was your mother-in-law, maybe you don't care, or maybe you like your mother-in-law. I don't know. What does it mean? You have accurate follow-up, you have clinical confidence, you have reliable patient management. It's a holistic evaluation. We take a holistic approach. We don't just look at one parameter, the nerve fiber layer. We look at all the information that's available to us. It's a systematic evaluation of each eye, and we follow the anatomy. Step 1, we go to the neuroretinal rim. Step 2, we go to the peripapillary nerve fiber. We follow the axon. And step 3, we look at the ganglion cell layer. If you look on the retinal thickness map, you might start to see patterns that look familiar from a glaucoma point of view. I can see that purple river going to the lake there, that focal nerve fiber defect, and I can see some notching of ganglion cell. I can see it much better if I segment the ganglion cell layer, and glaucoma is a horizontal problem. So I look for a symmetry or imbalance across that horizontal midline temporal to the fovea. And hopefully we're going to cover this in another session when we do some cases. It's a little bit like a snail shell pattern in the earlier stages. You can see clearly nerve fiber defects. We look at the neuroretinal rim profile. We look at the nerve fiber layer profile. We look at retinal thickness and ganglion cell thickness maps. And we look at deviation maps. This is really important. I see things in deviation maps that I didn't realize in the other information that we're getting. So deviation maps become very important, and at some point, maybe 50% of the time, you might see a structure function correlation, but remember that your fields are inverted and upside down relative to your OCT. You can see everything you need, including fields and color fundus photography. You could see both eyes at the same time. I see progression. This is an interesting progression, actually. Looked like a little superior glaucoma notching, but in fact, the deviation map is a more circular pattern, a red circle sign that we don't really associate with glaucoma. So maybe this is something else. You get the whole picture. You don't miss anything. And if you look at all the information, you can be confident with your glaucoma assessment. Finally, this might allow you to discriminate glaucoma from neuro-ophthalmology. If we look at the sequence of scans that we get from a glaucoma patient, including the visual field, and compare them to an example of a neuro-ophthalmology patient, they look different. And don't be surprised, you might see a clear field when you've got a red circle sign on your deviation map on your ganglion cell. Consider there's a family of optic neuropathies, and glaucoma is the most common optic neuropathy. Look how the patterns change within the family. At the top here, we've got a classic glaucoma patient, for example. In the middle, there we go. We've got neuromyelitis optica. So look at the different patterns of the retina thickness. Look at the different patterns of the ganglion cell thickness, the nerve fiber layer deviation map, and the ganglion cell deviation map. They're just pattern recognition. So you should be able to recognize the main different types of optic neuropathy you might have. Here's 3 more just to show you some different patterns again. We've got optic nerve drusen. We've got AON in the middle, and we've got compressive optic neuropathy, possible tumor at the bottom. Again, from the retina thickness to the ganglion cell thickness to the nerve fiber deviation to the ganglion cell deviation, you see different patterns. And these are the 4 most common types. So you might see a snail shell pattern if you have glaucoma. You might see a vertical pattern if it's a chiasmic or a post-chiasmic problem. You might see an altitudinal horizontal defect if it's possibly AON or a vascular occlusion. And you might see a red circle sign with MS, or often a toxic, someone that's got a drug problem or an alcohol problem. And you can see from the patterns that you get of your ganglion cell map where in the visual pathway that problem might be. So if we learn how OCT looks from glaucoma to neuro-ophthalmology and how those patterns change within different optic neuropathies, we can help discriminate perhaps glaucoma from non-glaucomatous optic neuropathies, like a glaucoma sequence, like an MS sequence, neuromyelitis optica, optic dystrophy, papilledema, anterior ischemic optic neuropathy, and compressive optic neuropathy. And this would give us increased clinical confidence. All these features, all these key benefits, our spectralis glaucoma DNA increases clinical confidence and improves your patient care. So I think it gives us all peace of mind. We can be much more confident. Thank you very much indeed. Sorry for overrunning and sorry for the dogs.
No, no worries. No worries. Thank you so much, Mr. Martin, for the wonderful talk for about half an hour plus. And it gives us, like an idea of how much we have it in our OCT. It is not just you pick up the red or yellow or the green signals alone. There's much more than what you just see in your, the print papers. So it is much more than that. So you access your system and then see how much of these important things like ART or phobia, disk axis, everything plays a critical role whenever we are looking at the OCT. It is not just you see something and then you come to some conclusion, and also looking at the patterns of the GCL, one may pick up what it is. Is it glaucoma or is it neuro-ophthalmology or is it something else? Also, we can really pick it up. So we have planned for 3 sessions of this OCT. One is today, and we have next week on 26th November, and also we have one more session on 3rd of December. So today we have mostly discussed on the machine part of it and what are the things that we have to look at in the acquisition and what is that we really see. Probably we'll just discuss more in the next 2 meetings. Again, we have some more clinical discussions as well in the December 3rd meeting. So, Manish and Deven, do you have anything else you want to add up in this? Or do you want to ask?
I just wanted to say that it was an excellent presentation, though some of the things we knew, but there definitely was addition and additional information uh, it was educative. What I wanted to say was, I think you're going to cover it in another session about the progression and how the machine analyzes progression. I think that you're going to take in another session. So I'll wait
We
for
have a
that.
couple of sessions, Manish, because
Yeah, that will be December the 3rd. We're going to go through clinical cases, and let me show you how I look on the scans that we get and what information you can see. And we'll do a couple of progression cases to show you there as well.
Yeah, so because I think that's a very important role that is played by imaging, and I think we would like to get more knowledge on that.
yeah.
Okay.
Martin, would you like to say something about this, the 1.14 micron change versus the 4 to 5 micron change?
Mhm.
What does it mean for someone to really look at this? Why is it that important?
I
Because
think
we
I
are
think
really looking at only the GCL. So I think I want you to just mention about how the Spectralis takes only on the GCL versus GCL IPL and what is that it is,
Mhm.
how important it is.
Yeah,
GCL
I mean,
complex versus only the GCL and the 4 to 5 microns versus 1.14 micron change.
that change is relative to the average nerve fiber layer. Okay, so it's very specific to that. It just means that if you, for example, if your reproducibility is not as good as that, it's just going to take you longer to identify whether the patient is changing or not. If you have a suspect patient, it's just going to take you longer. It could take you 3, 4, 5 years before you actually see the same change that we might see in the second year, for example. Let's to be conservative. So it gives you an earlier heads up. The only issue there clinically is, would the patient actually develop some kind of visual field loss because you hadn't identified that the structure was already starting to deteriorate? That's the clinical thing, bottom line, if you like. But as you're in practice, you probably have a slight different perspective, and you're taking a longer term view on that. If you look at ganglion cell, I'm looking at the patterns. I'm not looking at measuring loss in terms of microns of ganglion cell, for example. I'm looking at the patterns to see whether or not that patient is changing over a period of time. Yeah.
Yeah. So when we are really looking at the most of the OCTs, they give you the GC-IPL, both a complex, versus what we have it in the spectral is only the GCL. So how important it is to look at either as a complex or only the GCL, and what is its clinical relevance?
I think it's mostly theoretical. I think from that point of view, you might see similar information. Can't say that the ganglion cell itself is giving you any massive advantage. The theory is that the start of the problem is actually in the ganglion cell layer, and that's the reason why we segmented the ganglion cell layer in the beginning. Since then, other OCTs have combined layers, mainly because they can't actually see the interface between the ganglion cell layer and the inner plexiform layer. So it's a technical reason, probably more than anything else. But I can't say that from a ganglion cell layer point of view, that we would detect anything earlier than combining layers. And in fact, on the next version of our software, we're putting back on ganglion cell in the plexiform layer and GCC as well. For those people who are used to looking at that, then they can look in the same way. Yeah.
All right. Okay. So do you really say that looking at the thickness of the GCL is not going to be very useful than looking at only the patterns? Is it the GCL looking at the pattern is more important than looking at the GCL thickness?
I think so. I think it shows you the evolution and the speed of evolution of the change, and you can see that change is happening. I think if you look at all the research papers and the publications, they're looking at gross numbers. They're always looking at complete hemifields by comparison, rather than looking at focal defects. And I think we really need to focus on the focal changes that are going on, particularly as you move from glaucoma into non-glaucoma, because the location of those focal defects is different. So it's not about average loss. It's about where the location of the focal loss is, and is that relevant to a glaucoma type of deterioration or neurodegeneration, or is it relevant to a non-glaucomatous type of neurodegeneration? So it's much more important that we stop thinking about the average microns that we're losing and look at the patterns and where the location of those patterns are of loss.
Yeah. So it's quite interesting to see that we need to look at the GCL, IPL, as well as the RNFL, and also on the disc, and also look at the papillomacular bundle area as well, whether the patient has a temporal sign with the papillomacular bundle loss and also having a red circle sign. That makes completely a different diagnosis altogether, moving towards the neuroophthalmology rather than looking at the glaucomatous change.
Exactly. And I think this is the reason why I'm absolutely believing that we should have a holistic approach, whatever machine we're using. We should look at all the information that we have, because there may be something flagging up that doesn't fit with an idea of a glaucoma model eye. And that's what I've seen many times now. You see something that actually doesn't quite fit, and then you have to think, hang on a minute, is it really a glaucoma that I'm looking at, or is the neurodegeneration caused by some other problem? And as you mentioned, papillomacular bundle is the last area to go in glaucoma. So if you see loss in the papillomacular bundle, it's more likely it could be some other optic neuropathy present rather than glaucoma.
Yeah. Yeah. So basically today's presentation is mostly focused on how important it is for us to understand to take a good OCT rather than just reading the OCT, because taking a good dose, it makes it much more sensible for us to, pick up more things than just reading it. So thank you so much, Mr. Martin, and thank you for Heidelberg's support for educational program. Thank you so much. And I would like to request Manjula, can you just put up the QR code for people to scan the QR code
Sure,
so they
Doctor.
can send their feedback and also any questions. Please scan the QR code.
Sure, Doctor. Sure.
Yeah. Please put the QR code for people to scan. All of you can scan the QR code and send your questions and the feedbacks. So I hope everybody is able to see and then scan it. Please scan and then send your questions and also your feedbacks about this webinar. Thank you so much. Till next week. Thank you so much for joining us today. Thank you all.
Shall I do stop staring, Doctor?
Yeah, thank you. Devan, you have any questions? Sorry, Devan, I didn't ask him. Devan Tuli?
I think it's.
Okay, all right. Anyway, thank you so much, everyone, for being with us today.
Thank you very much. Thank you. Thank you, Martin.
Yeah.